Hi everyone. This week, one of the topics we're going to be discussing is prenatal and newborn therapy in the NICU, or the Neonatal Intensive Care Unit. So after this lesson, I'd like you to be able to describe the neonatal reflexes and recall at which age each reflex becomes integrated, articulate the role of OT in the NICU practice setting as well as some common therapies used, and be able to direct families of babies to beneficial resources related to their child's development. So first, when thinking about therapy in the NICU setting, you got to think about why babies end up being in the NICU to begin with. There are several prenatal and perinatal influences that may result in a baby being born prematurely or putting them at risk for developmental delays. So first, there are genetic concerns that can result to a baby being born prematurely. There are maternal factors, such as those listed here, and there can also be birthing events that result in complications leading to a NICU admission. One resource that I want to draw your attention to is the babycenter.com website, and there is a week-by-week fetal development feature within the website. And just when thinking about babies being born prematurely, if you were to work in the NICU practice setting, you would want to know what to expect for that baby's gestational age. So for example, if a baby was born at 23 weeks, you could go to this website, click on 23 weeks and see what an infant at 23 weeks looks like developmentally in terms of physically and in terms of their sensory development. So this is a great resource to keep in mind. You can pause now and go visit that website, or be sure to check it out after you finish viewing this PowerPoint. Another thing you'd always want to be considering when working with premature infants, whether you be in the NICU setting or if you're working with premature infants after they're discharged from the NICU, you always want to be considering their adjusted age. So with infants who are born premature, we are looking at their development in terms of their adjusted age, which is their age from their due date, versus their chronological age, which is their age from the date that they were actually born. So we just always want to be looking at that adjusted age, and that's what we would expect them to be doing developmentally. So say a baby was born 3 months early, and now they are 6 months chronological age. Well, when we take into consideration that 3-month prematurity, they are 3 months adjusted age, so we would expect them to be doing what a 3-month-old is doing, not what a 6-month-old is doing. And we typically adjust for prematurity through 2 years of life and expect at that point that the baby's caught up developmentally. Different developmental assessments will specify when you should be adjusting for prematurity in terms of scoring the test. So some different things that are looked at birth in terms of an infant's development is their APGAR scores. And you can see this picture here describes how APGAR scores are determined, and that's usually by the doctor or nurse in the delivery room. We're looking at reflexes, different blood tests to identify metabolic or genetic disorders, looking at ears, eyes, limbs, abdomen, skin, genitals, getting the height, weight, temperature, as well as the head circumference and shape, and then also doing a gestational assessment, which is looking at physical and neuromuscular maturity. So these are things you'd want to be familiar with if you were an OT working in the NICU setting. So in working with these infants, it's important to be really familiar with primitive reflexes and automatic reactions. This will definitely be a part of your assessment. Now, I'm not going to go over each of these in great detail because it's part of your online activities this week to view some different videos that show you these different reflexes. However, I did want you to have this information in written format to be able to reference later for your learning assessments, when you're on field work, and then in your future practice as well. So wanted to make sure you had it in written format. These tables are organized so that it includes the stimulus to test each reflex, the response that you're looking for, the age of the reflex emerges, and the age that the reflex should integrate or disappear. So this page and this page have all those different reflexes, and again, you'll watch videos that will show you these this week, and a couple of pictures here as well. And then this table describes the automatic reactions, so protective responses, head righting responses, neck on body body on body riding, and equilibrium reactions. And again, the table includes the stimulus, the response, and the age the reaction typically emerges. When working in the NICU, you're also going to be assessing the sensory development of the baby, so looking at their vision and their hearing. You can see as far as visual acuity, a newborn is seeing at 2600, meaning they see at 20 feet what we as adults see at 600 feet, which is kind of crazy to think about. And then their vision develops to a nearly adult level by their first birthday. And then obviously things like color and depth perception are developing as they get older. In terms of hearing, newborns can't hear soft sounds very well and display auditory preferences, and then as they mature into infants, their sensitivity to soft sounds and pitch improves, and they develop the ability to localize where a sound is coming from. You're also going to be assessing their touch, and then how they interpret smell and taste as well. So NICU as an OT practice setting, you'll hear the term neonate or newborn. And so a neonate is a baby who is born prematurely or who is acutely ill. Working in the NICU is not considered an entry-level practice setting. And this week in your online activities, you have assigned to you the AOTA statement, the AOTA practice statement about working as a NICU therapist. The consensus is that therapists should have at least 2 years of pediatric experience before practicing in the NICU. And it's important that the therapists identify a mentor and that they continue to complete continuing education regarding therapy in the NICU in order to develop their skills as a proficient practitioner in this setting. OTs in the NICU help lay the groundwork for child's future development of occupations, and in a couple of slides we'll look specifically at the common therapies used. Also in this week's online activities is a video entitled Preemies in the NICU, a visual tour. And this would be a good place to pause this video and go over to that video and take a look at what the typical NICU environment looks like so you get a feeling for this type of practice setting. And then you can return to this video. Welcome back. So looking at some of the specific priorities for therapy by age of the newborn, between 22 and 28 weeks of gestation, the therapist is really working to protect the eyes from light and protect skin integrity. These babies have extremely thin, fragile skin, so with all the different lines that they're having put in and the different bandages that are being put on, we really got to be careful with their skin. From 28 to 36 weeks, therapists work on protecting sleep and reducing stimuli and promoting the NNS, which is the non-nutritive suck. And between 36 and 40 weeks, therapists are promoting healthy visual development and working on feeding skills. So these are just kind of some specific priorities based on gestational age. You'll also hear the term neonatal therapist frequently in the NICU setting. And also sometimes you'll also hear developmental therapist. Both of these terms can be used to describe an OT, PT, or SLP working in the NICU practice setting. There's a lot of crossover between what these therapists do in the NICU setting. Regardless, they provide direct care and consultation and really focus on treatment and prevention of developmental problems. There are two common models that are used in the NICU practice setting. So if you were a therapist working in the NICU, you would be familiar with one of these models. The first is the Universe of Developmental Care model, which really emphasizes a patient and family-centered environment within the NICU setting. This approach recognizes the interactive link between all of the developing systems of the baby as well as their caregivers, while also providing a practical basis for developing individualized treatment plans within the complex NICU environment. The Integrative Developmental Care model expands on the Universal Developmental Care model, but also adds additional focus on developmentally appropriate positioning and handling, as well as optimization of nutrition and sleep and protecting the skin. So Case Smith describes both of these models in more detail, so be sure to review that portion of the assigned chapter for this week to learn more about these models. So some common therapies or interventions used in the NICU. it's important to consider how the intrauterine environment differs significantly from the extrauterine environment of the NICU. The intrauterine environment protects the developing fetus against harsh outside stimulation that they're not yet ready to process, including tactile, visual, and auditory stimulation. But after a premature infant is born, there are sudden demands such as breathing, regulating their body temperature, moving against gravity, adjusting to different auditory and visual input, coping with a lot of invasive procedures, and having frequent sleep disruptions. So the premature infant's central nervous system is not quite ready yet for all this overwhelming stimuli provided by the NICU environment, and negative sensory experiences start to replace positive sensory experiences, which can permanently alter the brain's development. Therefore, a major role of OT in the NICU practice setting is to create and monitor a healing NICU environment. So frequently in this setting, OTs are working with hospitals to design optimal NICUs and educate other team members on the impact of direct and indirect sensory stimulation on the baby's development. OTs frequently make recommendations regarding light and sound modifications in the NICU as well. So some other therapies used, OTs really work on facilitating and promoting skin-to-skin or kangaroo care. Skin-to-skin meets the infant's need for touch and supplies them with proprioceptive input, as well as helps them to regulate their temperature. Massage is being increasingly recommended as an intervention in the NICU. Studies have been showing that infant massage is associated with multiple physiological, neurological, behavioral, and neuromuscular benefits for infants, as well as having a positive impact on parent stress, attachment, and self-esteem. OTs use a family-centered approach to minimize avoidable family stressors while encouraging family participation in the baby's care. And they also play a vital role in educating caregivers on how to read the infant's cues, as these cues communicate the infant's needs and status at any given time. OTs can coach caregivers on the use of a slow and interactive approach with their infant to support their development. And along with this, OTs can educate family members on proper skin care, like we mentioned earlier, just really protecting the baby's skin, and instructing the caregivers on proper bathing techniques and removal of bandages to protect the baby's skin. Lack of appropriate NICU positioning can have short-term and long-term, can result in short-term or long-term positional deformities, which can have functional problems as the child grows older. So OTs in the NICU work to stimulate flex, contained, and midline positions to minimize positional deformities, improve the baby's muscle tone and postural alignment, and improve their motor patterns. OTs often frequently perform passive range of motion and splinting to minimize structural and neuromuscular deformities and to promote healing and comfort. Another prominent area of intervention for the NICU OT is going to be feeding. OTs work with mothers and infants on breast and bottle feeding by addressing non-nutritive sucking, nutritive sucking patterns, and suck, swallow, breathe patterns. OTs can also help caregivers to understand their infant's feeding readiness by observing their cues. So these are all common areas of therapy or common interventions used by OTs in the NICU. Okay. So I just touched on some of the common interventions used in the NICU practice setting, but I also want to encourage you again to read Chapter 21 in Case Smith and O'Brien, as well as the AOTA NICU practice statements that's listed in this week's online activities for more in-depth information. A couple of other resources here are the National Association of Neonatal Therapists and the Handlehold website, which both have excellent information regarding OT in the NICU. I just want to reiterate the importance of a family-centered approach in the NICU, and that it's important to address the NICU experience for the entire family and not just the infant. So it's important to be sensitive to the fact that parents may be experiencing guilt and thinking that their baby's premature birth or medical issues are due to something they did. So just to be sensitive to that and to be using a family-centered approach. Just wrapping up, thank you for listening. Make sure to complete the NICU resources activity listed in this week's online activities and be ready to bring your thoughts and questions to class this week.